The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus. We're talking about a fascinating topic this month. We're talking about the relationship between congenital heart disease and neurodevelopmental issues. And we have had an expert panel, rotating panel of experts who have been very kind to share their expertise. This week, we're rejoined by Sarah Winter, a developmental pediatrician from the University of Utah, and Laura Wood, psychologist, both of whom work very intimately in the Heart Center Neurodevelopmental program at the University of Utah. Welcome back, Sarah and Laura.
Thank you. Thanks for having us back.
Thanks for braving another episode of this. Now, since we last talked, have either of you developed any disclosures?
Not for me.
And I continue to have a consultantship with Rialto Life Sciences, but it doesn't affect this material.
Okay. Let's dive back in. Sarah, we're going to sort of continue our conversation from last week. So why is this so important to primary care providers? What do they offer in this equation?
So these kids, and we've established in our previous conversation that these kids are at high risk for lower severity but high prevalence neurodevelopmental disorders. In our clinic, as we discussed, sees kids at 4 different points and does more extensive developmental testing, which is not the same as what a pediatrician can do at their office. They're doing surveillance quite well. They're doing standardized screening tests quite well. But as you know, you don't have time to do a full speech evaluation or a full motor assessment. So these kids are going to get standardized tests on all areas of development, depending on the age that they are. And then the pediatrician translates the findings of those to action in that child's community. I think that's where the pediatrician can be really helpful, is if we're recommending speech therapy, the pediatrician would know what are the speech therapy resources in that community, because families don't want to travel for therapy. They might travel for heart surgery. That might be fine, but they're not going to travel for ongoing speech therapy or ongoing occupational therapy or feeding therapy, as many of these babies need. So the pediatrician can help with that. They can help with communication with the school in their community, because children live in communities. So we want our recommendations to flow out into where the child can receive that kind of intervention. And if any intervention can be done with the parent themselves, I know parents are very willing to help their children in any way they can, and pediatricians can support that too.
As a pediatrician, one of the things that I think is one of the richest parts of my practice, and one of the things that I think I can leverage maybe more than most other things, is the relationship that we build over time. You guys see them times, I see them many times. I see them when they have an illness. I see them in good times and bad times. And I would hope that gives me a certain amount of ability to communicate with people, and I hope encourage them to be able to get the resources that they need. Are there any other practical steps that you would recommend in terms of integrating this sort of surveillance into practice?
I think, pediatricians are already doing surveillance. So this is not different than what you would do with other patients. What you're bringing is this immense knowledge behind about, every pediatrician has rotated through an ICU before. They understand what this family has been through. They can read the cardiologist's report. Not that, we're not all experts in echoes, but at least we can read the cardiologist's interpretation and know, is this child sick? Is this child not sick? What about these developmental tests in the context of what's going on? And try and help the family integrate that information. And then also, sometimes we have the great pleasure of saying, your child's doing fine. Your child's doing great. And what a celebration you can add as a pediatrician to that family to say, wow, look at this testing. Look at how great he's doing. And, I would be so proud if my pediatrician said that about my child. And because I did look to my pediatrician for every bit of guidance or what I should do next, even though I'm a developmental pediatrician myself. I didn't trust myself with my own children about that. I
Sure,
trusted
yeah.
my
Yeah.
pediatric provider.
A couple of months ago, we were talking to somebody about dealing with office-based emergencies, and her point was one that I think generalizes over many topics, and that's that we don't expect a pediatrician to be able to deal with everything that happens as a result of a finding. What we expect is that you can recognize a finding and enlist the right help. That's exactly what we're talking about here, isn't it?
Exactly.
I know that most of these kids are going to be referred from their diagnosis on, but sometimes there may be kids who have fallen through the cracks. There may be kids who have moved from other areas. What's the best way for a primary care provider to connect families with a program like this one?
Yeah, so we have a referral form that you can just send your child in. Make sure you make a note for, HCMP, if you want to be brief, Heart Center Neurodevelopmental Program. Because there are referral criteria for our clinic, our nurse coordinator, Andrea Smith, is excellent at reviewing those to make sure that this child qualifies. If there's a concern and the child doesn't qualify for us, we'll address that too. This clinic is part of the entire developmental assessment clinics, and we have other resources for children. But if you're referring a child that meets the criteria based on those guidelines that we spoke about in the first and second episodes, then that referral will get read by Andrea Smith, and she'll make sure the child gets into clinic.
And we referenced an infographic a couple of weeks ago that will be linked into show notes. The nice thing about this infographic is it sort of helps you walk through some of the decision-making process. And I think it's very helpful. I'd refer our listeners to take a look at that in helping them know how to navigate this sort of thing. Laura, do you get to see all the patients in the clinic who need to be seen?
I certainly wish we did, but absolutely not. The truth is that the majority of children who are eligible for cardiac neurodevelopmental follow-up will not ever be seen in an established cardiac neurodevelopmental program. Nationally, the average is somewhere close to 29% of children who are eligible for these clinics are actually seen. We're pretty proud here that we've reached closer to 40%, but that's still over half of children who are eligible for this clinic are never seen in this clinic.
Can I just ask, so how do we miss the other 60%?
There's a lot of factors that go into that. Part of it is the logistics of time and space. We've talked a little bit before about what this clinic looks like. It is a big undertaking for families and for providers. There's a limited amount of space. We have a limited amount of providers. In addition to that, some families don't live locally and it's more difficult for them to get transportation here. There are outreach efforts we do by telehealth or by, communicating with families in other ways. Those would probably be the main factors that play into whether we see kids or not. And then a part of it is awareness of the services that are available. A group of us who are part of the Heart Center Neurodevelopmental Program also go inpatient and meet families before they're discharged. We talk about the recommendations and the resources available. We tell them about this outpatient clinic. So a lot of them are getting information before they discharge from the hospital, some before their child is even born. But there's a lot going on for these families. These are families who are dealing with sometimes multiple surgeries, different providers. And so to have another clinic is sometimes a lot for families as well.
And they often have other children and many responsibilities, and it's hard.
It's hard.
It's really hard. So what other sorts of resources do we draw on?
Well, so for the children who do and do not attend our follow-up clinic, there are still plenty of community-based resources that are helpful for families before, during, after discharge from the hospital. It's really essential that these systems of care that are available to families collaborate and work together. I think of it kind of as forming a net for the families, that we're all one string in this network that helps families not slip through the cracks. So we may not be seeing everyone, but hopefully they have a pediatrician who is at least aware of some of these things to look out for. Hopefully they are part of a school system that are aware of what to look out for. As our group, there are several recommendations and referrals that are nearly standard of care for most of our families. The first of which is early intervention. Early intervention is a program that every state, I know most of your listeners are very familiar with early intervention, but it's available in every state. And what it is able to do is provide developmental monitoring, developmental assessment, and developmental interventions for families inside their home from birth until their child turns 3 years old. Every child who goes through heart surgery in our center before the age of 1 has an automatic referral place for early intervention when they discharge from the hospital. So before we even see them in our clinic, they're already being referred to early intervention services. When we see families again for a visit at 9 months old or 2 years old, we're following up on that development and seeing if they were able to access early intervention. And if not, is a new referral appropriate at this time? One important thing I think to remember for early intervention is that when a child is first discharged from the hospital, they're often infants, they're often as young as 30 days old. The expectation for a baby is very low. And so a lot of times our families do go through early intervention and they pass the milestones they're meant to. And so they're discharged quickly from services. Part of our goal is also to educate the early intervention providers about why these children, even if they don't qualify right at this time, should continue to be monitored and continue to receive support, even if right at that moment they are not eligible for services.
Other programs?
Absolutely. So the Utah Parent Center is one of our go-tos as well. Utah Parent Center is a unique organization in that it is led by and run by parents of children with developmental delays and disabilities who have also been trained in the systems of care that are available here in Utah. So it's a helpful resource for families because they're talking with other families who have been through similar situations and have had to navigate systems of care. And they are able to support accessing early intervention, helping with insurance questions, starting the school. What does that look like? IEPs and different supports available in the school. So we have a colleague who works there that we lean on quite a bit as a kind of extension of our program to continue to support these families beyond when we see them in the clinic. Another common resource is for school systems. We provide information to schools about congenital heart defects and what it could look like in the classroom, and we provide the reports for families to share with the schools to inform additional accommodations or supports that would be helpful there.
The key with all these things is that we're reaching out, right? That we're trying to involve people because, as you mentioned, sometimes a child will be doing well at one stage, but we're all work in progress, and making sure that as we get through all the physical challenges that kids may go through, that we've made sure and helped with the developmental challenges.
And it's not limited to just the child either. Our clinic, as well as outside of our clinic, we focus on the family functioning as well. These are families who have been through a lot, through a fetal diagnosis, through hospital stay. It is very common for us to meet with the family and have other, maternal mental health identified, anxiety for the child or for siblings. Parents have experienced trauma as they go through these surgeries, and so there's PTSD for the family sometimes. Our clinic also supports access to maternal mental health or parental mental health resources, behavioral health for medical anxiety for children, and really thinking of that family as a whole and what do they need.
Well, number one, the clinic's a great program. And number two, it really is important for us to remember that there are resources available, and resources are only useful if people use the resources. And as pediatric providers, we're in a position that we can encourage people to be able to take advantage of those things. Laura, anything else that you think we ought to think about before we're done this week?
As far as other resources, I was just thinking about, we also make referrals a lot of times to clinic-based developmental therapies, occupational therapy, physical therapy,
Oh,
speech
absolutely. Yeah.
therapy, feeding therapy, all the normal that you would already be familiar with, and thinking about how those fit into the picture too.
But when you say all the normal, again, so much of this hinges on recognizing the problem and then getting people connected.
I want to brag a little bit about Dr. Wood's project. She's got a couple of projects that she's passionate about. And one is that she developed a communication tool between parents and educators, and anybody can access it. And we'll be happy to share it with anybody. But
Can we link to it in show notes?
Sure. It's just a tool that adds to our evaluation to give to a teacher. so that the teacher can understand that this child has these issues related to, their development and their heart disease. So that was one project. And another project she's passionate about is getting these kids physically active, because many of these kids can move and can participate in exercise. But you can understand the fear that some of the parents have in trying to initiate any kind of physical activity. So this is a project near and dear to Dr. Wood's heart, and she is trying to promote this. It's going to be a years-long effort, I'm sure, but we think a lot of these kids, some of our parents are great. They get their kids out and play all kinds of activities, but some are really fearful. So look for more information about that coming.
Excellent. Well, Sarah Winter, Laura Wood, and to our past guests, Jory Harris and Christy Glotzbach, thank you so much. Number one, for taking this problem on, for making a difference for this population, but also for sharing your passion. It's just one more thing that we need to be vitally interested. And most of it just really comes from being aware and having our consciousness raised as you have done. We'll look forward to dealing with some questions next week. Please send your questions to questions@vcurb.com, and I'm sure there will be some great questions. Until then, thanks so much for your time and for your expertise. Thanks to Elisa Stoddard for making this sound like a podcast, and thanks to Janice for listening. And we'll talk to you all next week. Thanks for joining us. We look forward to getting together again next time. The Virtual Curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Phil Wirkus, who composed the theme music. See you next time.